This is a fourth, or actually a fifth YouTube video that I've placed. It's going to be talking about introduction techniques that I've used in my office for 50 years when using nitrous oxide oxygen. If we take a look here, I've posted four others, one of which was done by Dentaltown, and I've been asking dentists get continuing education credit for watching the presentation. Well, I would hope you can. It's the same presentation that I've presented many times for various dental schools and continuing ed programs. But do realize this is being recorded in June of 2016. And as times go on, things change, discoveries are made. It may not be valid even next month, let alone 10 years from now. So it's the best techniques that I'm aware of today in June of 2016, but it might not be in 2026. Realize also I'm a general dentist, although I do have a background in anesthesia, and my emphasis is on information that is needed and can be used by general dentists in their practice. It's presented by Second Dental Opinion, which is an entity I use for my teaching, and I'm Fred Kornstrom. I'm a dentist. I hold 4 fellowships and some diplomats, and dentistry's been very good to me. I've been practicing now. I'm going on my 52nd year, although I've trimmed back to 2 days a week. It's number 104 in the series on oral sedation, nitrous oxide sedation, fear and pain control. And the topic of this video is nitrous oxide introduction techniques. And there's some plus items at the end that really don't have anything to do with nitrous introduction, but they're good information nonetheless. So here I am. I'm a dentist. I like to fly. In fact, I'm a certified instrument flight instructor. And my email's here, fredq@comcast.net. If you've got any questions, please feel free to email me. If you want credit for the course, it's possible in many states just to watch it and record that you watched it and how long it took you to watch it. Some states, like Oregon, requires a test and certification that you passed the test. And if that's required by your state, email me at fredq@comcast.net, and I have a short quiz that I'll send you. You can fill it out, send it back for grading, and then I'll write a letter certifying that you passed the test. There's a slight charge for that, $30, just to cover my postage and envelopes, etc. So, private practice hints and considerations. Another technique for the introduction of nitrous oxide sedation. We're going to talk a bit about the bag valve and mask and about an automatic external defibrillator and other topics. It's a potpourri of techniques and hints for those of us in private practice. We're looking for a simple, time-efficient method to use when administering nitrous oxide to our patients. And the modified technique that I use is very time-efficient. It is very safe. It works very well. I asked dentists, how many of you have ever used your bag valve and mask? We're all required to have them in our office. We called them bamboo bags when I graduated. The important thing is, have you ever practiced with it? And can your staff use it? Usually the dentist is the oldest one in the office and the one most likely going to need to have somebody do rescue breathing for them, other than possibly patients that use sedated. So I practice on my staff once a year to be sure that I still have the skill, and I require them to practice on me once a year. The most likely person, or most likely cause rather, of a cardiac arrest in a sedated patient is lack of adequate breathing. So it is important we know how to assist breathing. The slow induction technique, which is one that we've taught in our courses for going on 47 years, is a technique where you start by giving the patient 100% oxygen for 5 minutes, and you increase the flow slowly until the reservoir bag neither completely collapses or gets completely full. And that then becomes their minute volume. How much gas in liters per minute that they're bringing into their lungs and exhaling on a minute. Once you've determined that, you leave the minute volume or the volume of gas coming from the machine at that setting and increase the percentage of nitrous oxide 10% each minute for 3 or 4 minutes. So we spent 5 minutes determining the minute volume, and then we spent another 3 or 4 minutes getting the patient sedated. What are the advantages to this technique? Well, it's a great confidence builder for a new provider of nitrous oxide sedation. Things happen very slowly. You never get scared. It's very good for very apprehensive patients. I've had patients in my office that were so fearful. When I put the mask on, they tend to freak out. So I let them just breathe 100% oxygen for a while to get used to breathing through the nose piece. The disadvantage of it is you're looking at 7 to 10 minutes per patient per day. And if you use nitrous oxide on a lot of patients, and there was a time when about 80% of my patients needed it, in fact demanded it, you could lose an hour a day's production just with this very slow introductory technique. The next technique that we've taught in our courses for years was rapid induction. The advantage of it, it is very, very fast. Well, how do you do it? You put the patient on 80% nitrous oxide or 70%, whatever the maximum is that your machine can put out, and have them take 3 breaths. You've already established their minute volume, so you know what amount of gas you're going to be needing. And then each, at about second breath, ask them, how are you doing? Are you feeling anything coming on? At the third breath, turn the machine back to the percentage that they were comfortable with the last time and let them breathe that. Now, when you make that change, you need to squeeze the bag and empty it of the 70% nitrous oxide, because if they keep breathing that level, they're probably going to get uncomfortable. The advantage to this, it literally within 30 seconds, certainly by a minute, you have a patient who's relaxed. The disadvantage is the sedation comes on very rapidly, and it can be very frightening for the patient if they think they're losing control, or if you have a patient that hallucinates. I got into that in the complications and contraindications video. But if a patient sort of loses control, it can be very stressful for the patient as well as the doctor. And when you use this high a concentration, if you've got somebody who needs much less and you're using this much, there's a greater chance that you could trigger a vomiting episode for you, which isn't particularly dangerous because they're conscious, but it certainly is messy. Or you could have them hallucinate on you. I would say, and this is judgmental on my part, you probably don't want to use this technique in your office. Yes, it's fast, but it's not much faster than the technique I'm going to talk about here in a minute. And you do see more problems with it. So I heard Harry Lange, who was sort of the first person that wrote a book on nitrous oxide. Nitrous had been used for, I don't know, 150 years, and the techniques that it was used with were a little bit dangerous, I think. They literally gave 100% nitrous oxide until the patient went to sleep. They snatched out the tooth and hoped that the pain of the extraction would restart their heart. And lots of people got nauseated. There was lots of hallucinations. When I first opened practice, there was a real gentleman who had a practice next door. He'd been in practice by then, I'm guessing 40 years. He taught part-time at the dental school. He came over to welcome me into the building and saw my nitrous setup, and he said, "Oh, yes, I used that many years ago." He said, I stopped using it the day that I had people vomiting in both operatories and the reception room. So we needed a better technique than the one that had come down historically. So Dr. Lange added a technique that there was an air valve on the mask, and the thing that I've criticized him about for many years is he felt you needed to have the patient breathe some room air to get physiologic nitrogen. And I think we all know nitrogen is 79% of what we breathe. But he kept an air valve open, which did probably lead to contamination because when the patient exhaled, their exhaled air came out of the air valve. He started with 5 liters per minute of oxygen and 2 liters per minute of nitrous. Well, this is a bit more volume than you're probably going to need. Most people use about 5 liters per minute, some a little more, some a little less. He then decreased the flow of oxygen every minute by 1 liter until the patient was relaxed. So at 5 liters of oxygen, 2 liters of nitrous, which is roughly 20% nitrous oxide. When he went to 4 and 2, you now have a 33% mixture of nitrous oxide. If after a minute you still had no effect, he would go to 3 and 2, and by then you probably were getting an effect of nitrous, and that's a 40% nitrous. So most people are pretty relaxed by 40%. And so you got the desired effect. It took 2 to 3 minutes. I really didn't think you should have an air valve on the mask or that it should be open, and now you can't find masks with air valves. The technique that's my normal introduction, and it's used by most of the dentists that I've taught most of the time in their office. It's used by me all the time. So that's close to 100,000 uses in 47 years, and actually now 49 years. And well, what do we know about the patient? Well, we know first that almost everybody's minute volume is 5 liters per minute. So that's a good place to start. You want a total flow of 5 liters per minute. 30% nitrous oxide is very close to the level that most patients are comfortable with and use. So just go ahead and start with 30% nitrous oxide and a total flow of 5 liters per minute. And within a minute, most people are very comfortable. So why not just start there? And it's what I've done in my office, as I stated, for the last 49 years. 5 liters per minute, 30% nitrous oxide. And then you may have to adjust it because some people that'll be a little too much, some people it won't be quite enough. And you can adjust that very easily and give them another half a minute. It's used by most dentists most of the time. The advantage, it's usually very fast, 1 minute, maybe 2 minutes. It's very safe. You do have to pay attention to the patient and not the machine. And you ask them, how are you doing? Are you buzzy enough? Buzzy is sort of a nonsensical word, but if you're using nitrous, you'll know what buzzy is. Or are you too buzzy? And if you're too buzzy, if they're really too buzzy, take the mask off and let them breathe room air. If they're a little too buzzy, just turn down the nitrous a little bit or turn the oxygen up. The disadvantage of this technique, well, you have to make some minor adjustments, but that's true of any technique. You're using a minute volume, so you have to possibly make adjustments. If you've got somebody who's emptying the bag continually, you might have to give a little more volume. Or if the bag is overfilling, you may have to adjust that. You may have to adjust the concentration of nitrous to get just that proper sensation that the patient wants while you're working on him. And always remember with nitrous oxide, you must treat the patient, not the machine. We dentists and dental hygienists and dental assistants tend to be scientific technologists, and we are looking at the machine and let's see, I want 36% nitrous oxide and I want 5.2 liters per minute. People aren't that accurate. Their minute volume varies. The percentage of nitrous varies some. So you ask them how they're doing. So set the flow at 5 liters per minute, and if you have a percentage mixing machine, that's very easy. You put in 30% nitrous oxide, or if you have one that measures oxygen, 70% oxygen. Or you give 1.5 liters of nitrous oxide and 3.5 liters of oxygen to get that 30% nitrous oxide level. Make sure the bag's half full, add a little more oxygen if it's less than half full. Place the mask on the patient, and always remember the hoses go behind the head, not behind the chair. If you strap down a frightened patient by putting the hose around their head and then behind the chair so you're holding their head down on the chair, it is distressing for them. They can really freak out. And talk to the patients. How are you doing? Are you buzzy? Are you too buzzy? And as I've said a couple of times now, treat the patient. Listen to them. Are they buzzy enough? Are they too buzzy? Make the adjustments. So At the end of the appointment, Langa had us give patients 100% oxygen for 5 minutes. And some people have stated, well, that reverses the nitrous oxide. Well, it doesn't reverse the nitrous oxide, it dilutes it. The reason we still do that is we have our scavenging system going, and we talked about scavenging in one of the previous videos that I uploaded. We want to keep the trace contaminants of nitrous oxide out of the operatory because it's not good for our staff to breathe, particularly if they're pregnant or planning on becoming pregnant. With any technique, and this is the 3 techniques I've talked about, Langa's technique, and anybody else's technique that you might learn, if the patient goes to sleep or if they get more relaxed than they're comfortable, if they start hallucinating, or if things just aren't right and you can't figure out what's going on, take the mask off. You're never wrong by taking off the mask and getting the patient breathing on room air. They were fine when they walked in, breathing on room air. Get them back on room air, and then you can take a look and see, hey, what's going on? Why are we having these problems? And in a couple of cases, in my usage on machines that I had not owned that weren't in my normal machine, I ran into machines that were set up backwards, one of which I set up backwards. And the lady went to sleep, and I'm looking, this doesn't make any sense. She's on 80% oxygen, 20% nitrous, and yet she's not responding to touch, she's not responding to my voice. And I took the mask off, and within a minute she opened her eyes, and it was clear that she had been way too deep because the percentage, in fact, was 80% nitrous and 20% oxygen because the tanks were switched. That's happened at least 70 times in dental offices that I'm aware of here in the Pacific Northwest. So it does happen, and the most important thing you'll learn from any of these videos, if things are going wrong with nitrous, take the mask off and get the patient back on room air. So here's one of my favorite patients. This is my daughter. We've noted in the chart that she got along very nicely on 30% nitrous oxide. We're not in a rush this afternoon. She's not in pain. We don't have any reason at all to try to get her sedated quickly. So we know she's going to use 30%. We dial up our 30%. We dial up our minute volume here of 5 liters per minute, and we put the mask on. And then we take a look at the chart, see what we're going to do today, get any equipment in the room that we need to have in the room, etc. And she'll be relaxed in about a minute. This is a quick, easy induction. It's not overly fast. We never have anybody get too relaxed doing it. It comes on pleasantly, largely because we know what her minute volume is going to be and we know what her effective concentration is. How you doing? You feeling anything? So she's starting to feel something. That didn't take long, maybe a minute. Usually within a minute, maybe a minute and a half, you're ready to go. But consequently, there's no reason to leave a patient on nitrous for 10, 15 minutes while you're getting the anesthetic to take effect, while you go next door to adjust a denture. If you're going to leave the patient, put them back on oxygen, let them breathe for a minute or two to get the bulk of the nitrous out of their system, and then you can go ahead and leave them knowing that when you come back, you can have them ready to go to work within a minute. But when you leave the room, I strongly believe the nitrous oxide mask should be off, and that way you don't have to worry about someone deciding to get up and they're under the effects of the sedation, trip and stumble, injure themselves. If they're in the room on nitrous, they need to have, at a bare minimum, a dental assistant in the room monitoring them to be sure that they haven't gone to sleep. How do you know if they're asleep? You ask them, how you doing? Are you awake? Okay, she's responding to me, she's awake. What if she didn't respond to me? Hey, open your eyes. Light tactile sensation, she should be awake. You shouldn't go beyond that. This is not general anesthesia. She, at that point, would be a little sedated, and she would be more in just sort of dozing. If you're having to pinch her to wake her up, you've gone way, way too far. Now you're approaching general anesthesia, and we don't want to do that. There are various hazards that come along with anesthesia. Go ahead and shut it off. Okay, so that's I think, a reasonable demonstration of a very simple, very quick technique. Monitoring. In the bad old days, if you were pink, everything was good, you were conscious. If you were a little cyanotic and unconscious, you better take the tooth out and hope that the pain restarted the heart. And if they're this blackish color with a very purple tongue, you better get them on some oxygen too. That's no longer considered appropriate. Do you need a pulse oximeter to monitor their saturation when they're on nitrous oxide? And I think you don't need a pulse oximeter. I think there are a couple of states that require it, and I think that's silly because on nitrous you're getting typically 70% oxygen, 30% nitrous oxide. In room air you're getting 21% oxygen, so you have three and a half times as much oxygen breathing your nitrous mixture than you do breathing room air. And so consequently, your saturation of hemoglobin will always be 100%. So it really doesn't tell you much. What's a pulse oximeter all about? Well, we have a sensor that goes on the finger. It shines two frequencies of light through the finger. You can use a toe, you can use an ear if you have the right sensor. The unoxygenated red blood cells are more purple in color, and they absorb the purple wavelength of light. You also have a red wavelength that's absorbed by the oxygenated red blood cells. And sensors sense the amount of light coming through, and through the miracle of microelectronics, it then reads out a percentage. You're 98% saturated with oxygen. You always want to be above 90%. So there are little finger sensors here. I use one of these when I'm flying. You can see here when it was on this hand, patient was 93% saturated. Their pulse rate was 76. There are other pulse oximeters, a bit more expensive, that will print out a strip recorder, and I think if you're doing IV sedation, you ought to have one of those. Here's one that shows you the platysmograph, which is the blood flow, and it has an alarm. Now, if you're doing IV sedation or if you're doing moderate sedation, then if you're doing oral conscious sedation, I should say, I think you ought to have one with an alarm. In fact, it's required by most states. This one does not have alarm. These are very inexpensive, around $50 or $60 online, and they're remarkably accurate. So it doesn't hurt to have one in the office. If somebody starts to get lightheaded and you don't know what's going on, stick their finger in this and it'll tell you what their saturation is. And that's basically all there is to it. The SpO2 is the percent of saturation of the hemoglobin molecules. And on this one here, it's 98%, and the pulse is 80, which is a good thing to know and record. Gives you some baselines to start with. You need to have an extra tank of oxygen in the office, and you can't say, well, I've got oxygen on my nitrous system. Most states require a separate tank, small tank of oxygen. You need a bag valve and mask that you see here, or you need this one. There are some other smaller bottles. Check these every so often. I've been told that all of these valves leak. The small tank we have in the office, I've been watching now for 10 years, and its pressure is as high as it ever was, other than the fact that I turn it on every year when we do our emergency training to show people how to turn it on, but it's still 95% full. And they come with a gauge that tell you how much pressure is in these tanks. But you need one of these. It's very important. The bag valve and mask has changed. The old Ambu bag was made of rubber, and it sat under the sink in one of your operatories for 35 years. And someday when you needed it, you grabbed it and you squeezed the bag here, and the rubber by then had disintegrated and the bag fell apart in your hand. These are made of plastic, and they're very inexpensive. As I remember, I paid less than $20. What's this bag for down here? Well, if you hook this up to oxygen, and you should, this serves as a reservoir bag, and then when you squeeze the bag, the patient gets 100% oxygen. Take your hand off the bag. As the bag reinflates, it pulls the oxygen out of the reservoir bag, so they continually get 100% oxygen. And there is a pop-off valve here that lets them exhale. Some of them are in different colors. There are pediatric sizes, adult sizes. You do need a variety of masks because everybody is a different size. The other thing that I have in my car is a pocket mask, which basically fits in this very trim little container, and you open it up and you give a pull on this and it pops out so that it fits nicely on a person's face. And with this you can do mouth to mouth. There's a filter in here so you can inflate the patient's lungs, and when they exhale that goes out the side, so you're not at any risk from any diseases that they might have. I do not like this sort of a respirator. This is a variety, and they're way more expensive than the bag valve and mask. There's a button here that you push on, and it's hooked straight up to your oxygen in your line, and that button then inflates their lungs. Take your hand off the button, and when they exhale, it's released, and then you push the button again. What is it I don't like about that? Well, with the bag valve and mask, and when you practice breathing for somebody, you can feel if you're inflating their lungs. You can feel the compliance of their lungs. With this, all you know is that you push the button and their chest or belly rose, but it may in fact be inflating their stomach. It may not be going into the lungs, and you don't have that sensation. With a bag valve and mask, if you don't have an open airway and you're inflating their stomach, it'll feel very different. And that's why I encourage you, practice with this once a year. Have your staff practice with it. With this one, you don't get that feedback, and heaven forbid, if your oxygen and nitrous lines are reversed, and this is hooked up to the oxygen line, you're not giving 100% oxygen, you're giving 100% nitrous. And there was a case in an oral surgery office down in Texas where that was the case. And he had a young man who he put to sleep and got an IV started, and then had him on 100% oxygen, he thought, and the oxygen saturation started dropping. 95, 90, 85. So at 85, he started assisting the respiration. He grabbed this respirator device and started breathing for the child. And the saturation went down to 80, down to 75. He intubated the child and continued. The endotracheal tube attaches here, breathing for him. He thought he had a bronchial spasm. He thought he might have an allergic reaction. The saturation finally got down to 35%. His staff asked him twice if he wanted them to call up paramedics, and he said, no, I've got it under control. Eventually, they did call the paramedics when his saturation was 35. Paramedics came, put him on their small tank of oxygen, and his saturation immediately went to 98%. The young man woke up. He is partially blind. He's got a seizure disorder, and he has a marginal IQ. And he started out as an A student and a star athlete. For all of those reasons, I do not like that type of respirator. So what sort of respiration problems can you run into? You can have inadequacy, or if the patient, for whatever reason, stops breathing, you need to do something to help them. Well, we can control this. We can grab our bag, valve, and mask, and we can assist their breathing, or we can take over if they stop breathing. And it gives you time to call 911 and get the paramedics there. They're accustomed to handling these problems on a regular basis. One of our problems as a dentist when it comes to handling emergencies is, with any luck at all, you never see them. I have somebody try to faint for me about every 3 years. Well, you can't stay top on your game if you're only practicing every 3 years or so. There can be an obstruction. You could drop a crown that you're cementing, and that could get down onto the vocal cords, and they could be in laryngospasm. Now you've got real problems, and you really do need help. They can die, and you've only got something like 4 minutes, maybe 5 minutes if they're really healthy, before they're starting to have real severe problems. So what do you do? What are the signs and symptoms of respiratory inadequacy? They're having trouble breathing. They're cyanotic. They have blue lips. They have blue fingernail beds, and not from fingernail polish. If you've got a pulse oximeter on, they've got low oxygen saturation. It's below 90%. The old fireman trick was to You know, head tilt, chin lift, and look at their chest to see if there's any movement. If there's no movement, you got problems. I like to put my hand over their nose and mouth, which you'll see in a video here in a minute. And by doing that, I can feel if they're breathing because the air will be moving across my hand. The most important thing you can do at this point is have your staff call 911. Get the paramedics on the way. What do you do to position them? Head tilt, tip their head back, lift their chin. If their chin is allowed to fall down, fall back, that can let the tongue occlude the airway. And all you have to do is pull the chin up and forward and it will open. What about the airway? It can be a foreign object. A glob of alginate could get back there and could create real problems. I had some real concerns when we started letting untrained people take study models with alginate, because if the alginate's a little thin and it gets back behind their tongue, you know, you're going to see them retch and whatnot, but they have to inhale that down into their trachea, and then it sets up, you're going to have real problems. To the best of my knowledge, it hasn't happened, but I really worry about it. Laryngospasm, if you touch the vocal cords, if they even get a drop of saliva, and most of us have probably done this a time or two, we're taking a drink of water and we laugh or something or hiccup, and we get just a micro drop of water on the vocal cords, and they'll slam shut, and you don't breathe very well for a minute or so. It is an anesthesia emergency, which we saw on a regular basis, and we're very adept and able to take care of that. But most of us in the dental office do not have those drugs or the endotracheal tubes necessary to intubate somebody. Circulation, the good way to do that is monitor their pulse, get their blood pressure, use a pulse oximeter, and see what their saturation is. Depending on the patient's age and physical status, they've got between 4 and 8 minutes to live if they stop breathing or if you've occluded their airway with some alginate. And this is one technique that you can use that may save a life. The second would be to defibrillate if they're in ventricular fib or ventricular tachycardia. And that's why you need to take your healthcare provider basic life support course, and why you need to have an automatic external defibrillator in your office, so that if you have the unthinkable happen, you have a way of shocking them back into life. And the automatic external defibrillators will not shock somebody unless they have either VFib or VTAC. So treatment, tell the patient to take a deep breath. If you just got them too sedated but they're conscious, take a deep breath for me. That's the way. Blow it out. Take another deep breath. Blow it out. Do it again. Blow it out. How about the patient that's in syncope? They're trying to faint on you. You break out the ammonia inhalants and crush it under their nose. Well, I'll tell you about that. Ammonia is a very caustic chemical. It's very hard on lung tissues. I don't think we ought to have it in our emergency kit. I think it's a bad drug. Yes, it will stimulate them. They will try to punch you if you break it out under their nose because it's very, very pungent. All it really tells you is that they were playing possum. They really weren't asleep. A better way is to pinch the back of their upper arm and pinch hard and twist. If they don't respond, you've got a patient under general anesthesia or is unconscious for some reason. Why do you pinch that part of the arm? Well, it's a very sensitive part of the arm. And if you really think you have somebody who's not really responding, a good pinch there may leave a little bruise, and they'll be less aware of it if it's on the back side of their arm. But it's much safer to use. It works much better than your ammonia inhalant. Next thing we learn in our basic life support course is tilt their head back and lift their chin. If they happen to be a denture patient, you may actually have to put your finger in under their tongue and lift their chin up to open their airway. We're pretty good at working in the back of the mouth. Get your light back there, pull their tongue forward, and you may see a foreign object that you can grab with your high volume suction and get it out of there. At this point, I'd be aspirating the oral cavity. If somebody just vomited on you, they got a big mess in their mouth. You don't want them breathing until you've cleaned that mess out of there. So get their mouth open and clean it out. We're accustomed to aspirating in the oral cavity. Check their airway again. Try to give them a breath, and hopefully it'll work, and hopefully they will start breathing for you. But if not, you need to start rescue breathing. One of the things that can happen is if you have a patient who has an obstruction, you will see a rocking motion to their chest and tummy, much as you see here. Essence doing a pretty good, or Dee Dee's doing a pretty good job of showing this what you'll see. And although it looks like she may be breathing because you're seeing movement, in actual fact, the patient who's obstructed will be moving like this, yet they won't be moving any air at all. Another indicator of breathing has to do with the reservoir bag that's moving in and out. There's been several studies to prove that you can't reliably tell if a person is adequately breathing just by the fact that the bag is moving. And if it were moving this much, we'd be pretty sure she was breathing very well. And with this much movement, you really wouldn't know if that were adequate for her. So you can't reliably use the reservoir bag to tell just how much a person is breathing, or if they're breathing an adequate amount. You can only say something about the rate of their breathing. We have our two volunteers today. Dee Dee and Essence are both dental assistants of mine. If you ever have a doubt as to whether your patient is breathing, the first thing to do is to take your hand and lift their chin. Yes, for a couple of reasons. First of all, we're going to look and see if she's breathing. And secondly, if she is breathing, we will feel her breath on our sweaty palm. And Mother Nature takes care of the sweaty palm part if you have any doubts. Okay, so let her head down again. Okay, now get your... Okay, if we find that she's not breathing adequately, or she's not breathing at all, we're next going to have to take over and assist her respiration. To do that, we use a bag valve and mask combination that you see Essence is going to place on her face. She's going to put her fingers under her chin and lift up so that she opens the airway, and then she's going to squeeze the bag. Go ahead and squeeze. And she's taken over for our patient here, and as she squeezes, Dee Dee's chest is rising, and she's now breathing for it. It's quite easy once you tilt their head back to open the airway and take over breathing. And this is something your dental assistants should practice in your office on a regular basis. Okay. Now, I think it's important that yearly you have your staff breathe for you, and you don't want to be too easy a patient, because if you actually ever needed to do this for somebody, a couple of things may be noticed. First of all, if their chin is down like this, you may very well hear the following. Snoring can cause us to laugh, but it's not a laughing matter. In this case, it indicates that we have an occluded airway. One of the things you can do right now is to tip your head clear back and take a big deep breath. And put it down hard on your chin and take another big deep breath. And you'll notice a distinct difference in how your airway is. So the first thing you do if you're going to have your staff breathe for you is start out in this position, because that's probably where the unconscious patient would be, is with their chin down and their airway occluding. At this point, Essence is going to take over and open my airway and give me a breath. Now, one of the things you have to be sure you establish is a good seal with the mask. So in that case, she was actually down a little too far, and when she squeezed, she would feel that she wasn't inflating my lungs. So let's try again with the mask a little higher. And what I've just done there is put my face askew and created an air leak for her. Did you feel the difference? Did you feel a very definite difference? And I think it's important to do that, because your staff should feel how it is to try to breathe with an occluded airway, how it is to breathe when you've established a good airway, and how it feels when you have a leak. So I will do those three things for essence now. Okay, go ahead. Keep going. Okay, thank you. So first of all, I occluded. You had a hard time squeezing. And then she gave me two breaths that were normal. And then the last two breaths I had created narrowly. You notice the difference there. So I think it's important once a year for you, first of all, to practice on your staff so that you're confident. And in turn, I think it's important for the staff to practice on you so that they're confident. And of course, I look at it somewhat selfishly, being the oldest person in the office. I'm the one that's most likely going to need somebody to do this for me. So do practice. Now, you may not want to go out and buy yourself a $50 pulse oximeter, and there are some apps for your iPhone now. I found one here for $3.99, which actually works. It wouldn't be accurate enough to be doing sedation with it. But if you're out and about and somebody goes down and you're just not sure what's happening, you turn it on, you place your finger over the flash of your camera and run it, and it then will read out in the pulse rate and the oxygen saturation. It is probably accurate, plus or minus 5%, which is a good indicator for you if you don't have your regular pulse oximeter. But if you're doing oral conscious sedation or IV sedation, you need a real pulse oximeter with alarms. And we're looking here, two devices. The one on the left here is the end-tidal CO2 monitor. And what it shows is the last little bit of air that you exhale right here has the most amount of carbon dioxide because it was the last thing to come out of your alveoli. And that is the level of CO2 that you're exhaling. And it's normally around 37 millimeters of mercury. If you hyperventilate with such a machine, you see a bunch of little short breaths here, you can blow that down. Here, one of my assistants hyperventilated, and she was down to 17%. Conversely, if you stop breathing, in about 10 seconds, this machine's alarm goes off and alerts you that, hey, something's wrong. And it's much faster than the pulse oximeter. It takes about a minute for the pulse oximeter to show. This is a device I ran into at the Consumer Electronics Show in Las Vegas 3 years ago, I guess. It's a backing plate that fits on your iPhone, and your patient, you have them wet a finger and put one on each of the electrodes, and it will read out an EKG. Now, you get a lot of noise because it's very hard to be completely relaxed, but it'll work. And a live ECG is the one that I purchased for my phone. The fingers fit on the back of the phone here. That you have to sit very relaxed. You don't want to be holding this up with your hand. You really want it to be resting on a table or on your lap, because if your arm muscles are doing anything, you will see noise on the tracing. And an idealized tracing here, if a person was completely relaxed, and you can see the aspects. Here's our P wave, our QRST, and here's our T wave of repolarization. And it tells you what their pulse rate is. And you can enter the patient's name.
There are a lot of situations
and here you see it. I'm holding it up at the convention in Las Vegas. And there's a lot of noise in the tracing.
So this reads an ECG
But
as well
it
as
tells me what my pulse rate is. And I get a pretty good view of the P2RST complex. And all these little jiggles you see here have to do with the muscles in my arm. Costs around $100. I've used it twice in the office when somebody was doing weird pulse things. I'm a docent at our local museum of flight. I've used it a couple of times there when people were either hot, in one case it was hypoglycemic, they got really shaky. Well, I can put my phone on their fingers and I can tell, hey, their heart's beating at a normal rate, that's good. I've got my pulse oximeter, I know they're saturated, so we probably don't yet need to call the paramedics. Let's see if we can't figure out what's going on. Emergency statistics, and this is really, really important. Here in Seattle, they have, the last count, I think about 60% of the population have taken CPR and are capable of doing life-saving CPR if they run into somebody who's unconscious and without a heartbeat. In all cardiac arrest victims that were shocked within 6 minutes, most of them lived. Whereas if it was more than 6 minutes, almost all of them died. That 6 minutes is a golden time. If they're in cardiac arrest, if they're in ventricular fibrillation or cardiac ventricular tachycardia, and you shock them, by shocking them, you can return them to normal rhythm, and a very good chance that they will live. The average time for an emergency response from 911 to get to the patient is 9 minutes in urban areas and 15 minutes in rural areas. Those of us in Seattle are very fortunate because there is no place in Seattle a fireman can't get to you in less than 3 minutes. But in the meantime, civilians will be doing CPR, which extends the time a bit until that shock is needed. So I think it's important that we all have an AED in our office, and there are demo models available that you can play with and learn how to use. And that way, if it ever happens in your office, I've never seen it in my office, I don't want to see it, but you have a way out. Now, I'm pretty old. I'm 75, and my wife is not quite as old as I am. We got a lot of old friends. And these automatic external defibrillators typically cost around $1,000. I figured, what the heck, I've got one in the office. I spend a lot more time at home than I do in the office, so we've got an AED at home also. And with that, this video is over. Again, if your state requires that you have certification, you watched it, email me, fredq@comcast.net. And I will send you a quiz, and take the quiz, and if you have to watch the video again to get all the answers right, do. Send the quiz back to me with a self-addressed stamped envelope, and I'll grade the quiz and send you a letter certifying that you passed the quiz. There is a $30 fee for that. Now, if you happen to be in the state of Washington, you can just tell the state that you watched the video and how long the video went on, and they'll accept that for up to 7 hours of CE. And so you can get credit for the course that way in many states. And if you have lots of questions, or any question in general that you want an answer to, don't be bashful about calling me.